And then the last group, Virginia Adams, a couple of projects on law enforcement and a relationship between health and the judicial system.
Thanks, Warren. There are lots of organizations in our communities, and including jails. So these are the places in which we live, we work, we play, and we love. And we have a lot of people who are in those jails who come back into our communities, who are part of our families. So in framing and looking at these issues, I first wanted to thank our guest who got our discussion off to a roaring start, and that was Joe Marquecho and Marsha Regenstein. So thank you very, very much. Both of them play real important roles here in this area. So in looking at, we can move it on. Looking at these, am I moving it? Okay. All right. Got it now. Okay. So in framing our issues, we wanted to look at the people who were in these jails, and especially the health issues that they had. We looked at mental health issues for the most part, substance abuse issues, and also their chronic health issues. They come with diabetes and some with even infectious diseases. So that's how we were framing that in terms of how we look at law enforcement, as law enforcement should be working with health professionals. We started to look at what we called, well, what Warren asked us to look at innovation. We were looking at the value of law enforcement and health professionals working together, and we found that for the most part, service providers who are in health don't know a lot about the law enforcement issues, and it's also vice versa. So the question became, how do we help each other? So our big innovation was a curriculum that would be helpful for all of us. The big issue too for us was a lot of experiential, doing experiences with the two organizations together, but for the most part, a curriculum that was common in the language that we use. How could we put these two things together? And one example was looking at the mental health facilitation curriculum that was offered yesterday. It's offered on different levels. Could we take something like that with our two organizations together and get something out of that? And also look at, make it simple, make it flexible. And everybody kept saying, and no PowerPoints. Decrease the PowerPoints, no PowerPoints. Do some ride-alongs, do some drive-alongs. Take these organizations, let them work together that way. We also had the recommendation that we would bring them to the service providers, and especially in our acute care facilities and in our emergency rooms, where we bring all of these patients, detainees in, but the way that we treat them as health professionals as if they belong to somebody else or something else and not a part of our communities. We need help with that. They need help with the language that they also use with the prisoners or with the jailers that they bring in. And we have to make a distinction between what's a jail and what's a prison. So we're looking at the local level and what happens in jails, not necessarily on what happens on a federal level when we talk about prisons, people in our communities. A part of that too was looking at one concept called de-escalation. If you're confronted in a situation with mental health people, and Dr. Lubrick talked about the folk didn't want to go through this whole cadre of folk who had substance abuse issues, mental health issues, homeless issues, that's the same population we're talking about because they're likely to be jailed. They're afraid of them. And if something happens, nobody knows what to do with them. So this whole concept of de-escalation, if that's happening, what does it mean? How do we help to de-escalate a situation as health providers and law enforcement without killing other people because we don't understand the behavior? Shadowing became a part of the curriculum. Did I change it? Okay. So these were our big innovations, our big takeaways. Training in an intake system that improves communication. Communication kept coming through over and over and over again. Communication between law enforcement and our health professionals. And there comes the question of how much information can you share? If they're coming into our systems and they have health issues, what does that have to do with HIPAA? What can be shared on a confidential level? If you think people have mental health issues and they're going to be violent and you can't predict that, how do you share that with an agency that's in the business of enforcing the law when you may be wrong? Those kinds of issues. Money. Facilitating a return to the community. Some of these, our people, detainees, we'll call them, come into these facilities for a very short period of time. But over time, they come back and they come back and they come back. Some come in for longer periods of time. So the question is, if when they're going back to the community, is there a way of discharging them where there's a connection to the community that we can help provide so that our communities are, yes, safer, but that everybody understands who's coming into the community and how we can best facilitate services for them. So here are our challenges. Resources, how do we get this curriculum to be broad spread? How do we replicate some of the services, some of the same kinds of training that the DC Police Department is doing in this area? Joe was saying that he can take his curriculum and put it in any country because they're already doing that, and especially as they deal with the vulnerable population of the gay, lesbian community, transgender community. How do you bring those resources to bear? How do you help people to understand that they do exist? And a part of that was talking with the social work system, bringing in another system so that everybody understands those challenges and how to get resources to them. Another issue was leadership. How do you have a champion in both communities so that we can bring all of this together? And then, of course, measuring. How do you know you've been successful when you do this? Well, the ultimate outcome is we reduce recidivism. We don't have people coming back to jail. The other piece is those folk who have health issues, not only are they taken care of while they are incarcerated, as they transition into the community, there's a way to most certainly plug them into the services. It has to do with how we get paid. And Marcia was talking about our Patient Protection and Affordable Care Act and how now more of the young men, especially young Black men who don't have services while they're incarcerated, will now have access to health care. Therefore, there is a way to take care of some of these health care needs. When they're in these systems, these are not the kinds of services or resources that are available to them. And then how do we sustain them? Electronic curriculum is a part of that. How do we have short-term modules that we can learn from, that use those that are interactive? And then the scale up. And that is how we do this cross-culturally, how do we do this cross-geographical areas. And we had a lot of ideas about replication, how to take them and where to take them and who should be taking all of these strategies to these different places. And I think Marilyn is still in the room, and we were talking about one initiative that was a blue ribbon, blue button initiative where all of the information could be on one of the detainees and they have the option of sharing what's going on with them. One example, we talked about this one example where, and I think everybody probably read about it at Rikers, where we had the veteran who was baked to death while he was at Rikers. He was a veteran, a Marine veteran, 56 years old. He was arrested because he was trespassing. He was just trying to keep warm. He was also homeless. When they arrested him, he was arrested because they wanted to keep him safe and warm. He was on antipsychotic medications, anti-seizure medications, and by the time they found him in his cell a week later, he was dead because nobody was monitoring that situation, and he just baked to death because it was 100 degrees in the cell, and he didn't have the capacity to pretty much get himself cooled off. So how do you prevent those kinds of things from happening? Where do we become involved? How do we become involved? How do we take those models and then put them in other places? So we didn't have a model. We just had all kinds of strategies that were coming in, and we want to have a common curriculum that we all can use and then begin to scale up and spread up. Okay.
Thank you very much, Virginia. Questions and comments? Yes, Bjork?